drug abuse, cancer,
measles.
Good evening once again, and welcome to another episode of Doctor and Call. It is a pleasure, as always, to be with you, and of course, we welcome all our viewers on GBN Television 7 and 11, our listeners on K105 FM, and of course, our friends on our Facebook page and our YouTube channel. This evening, we're discussing some common eye conditions and eye diseases, and we have a very special guest with us. He's an optometrist, and of course his name, Mr. Ryan Singh. It is a good time to welcome him. Mr. Singh, good evening and welcome to Doctor and Call. How are you?
Good evening, sir. Thanks for having me. Not bad. How are you?
I am doing very good. It's a real pleasure to have you. In fact, I'll tell you, it's been a while. We have not discussed conditions of the eye on the program. So I'm extremely delighted to have you, and we're looking forward to a rather exciting program this evening.
Well, I'm glad you have the interest.
Yes, indeed. So there are some common eye conditions, and we know the eye is one of the most important organs. Without that, I guess, commonly we will be grabbing at straws like in the dark. But of course, there are many things we can do to, protect our eye health, and to ensure that, of course, we maintain that. And we do understand with age, like everything else, there will be little issues here and there. But of course, we're looking forward to hearing from you all of the things we can do to help protect our eye health. So I'm going to start by asking you, of course, you're an optometrist, and you do come across lots of people on a daily basis with different eye conditions. So I want us to look this evening at some of the more common ones, and I would allow you to maybe start by sharing with us some of the more common eye conditions that you come across, and then we would go into them individually in detail and try to share some information with our audience. So I'll now hand over to you.
Okay. So, well, where do I start? If we have to start with common eye conditions.
Yes. Mm-hmm.
We can start on a very simple level where the conditions will not lead to any blindness. It usually does not deteriorate anything like that. These are the most common conditions an optometrist will. Mm-hmm. An optometrist is your primary eye care provider. It is the first person you will see when it comes to dealing with the health of your eyes. The main condition an optometrist will experience in his examination, his or her examination, will be refractive error. Refractive error is anything that deals with the lens in your eye. The lens in your eye is basically a structure that focuses light. Mm-hmm. Without the lens, your brain will not have anything to interpret. Okay?
Right.
So some people's lens, they do not focus light properly. And we call this an error, a refractive error. Refractive means the bending of light. So there is an error with the bending of light. There are different types of refractive errors. There is something called myopia or short-sightedness, which a lot of people know. There is hypermetropia or far-sightedness. There is astigmatism, and there are, less common cases. Things like keratoconus. There is corneal ectasia, which keratoconus is classified under. What is myopia? What is short-sighted?
Right.
Imagine you have a magnifying glass, and imagine you have a binoculars. A lot of people may understand how a magnifying glass works. It can focus on things very close. A binoculars can look at things into the distance. if we have to understand short-sightedness, it's very similar to saying with someone's eyes, instead of being like a binoculars to see far, it's more like a magnifier to only see close. If you take a magnifier and you look through that to see far, you will never see far with it. Okay, because it only magnifies stuff close up. So basically, myopia or short-sightedness is where the lens in the eyes, it only focus on things close.
Right.
Things that, yes, things that is within your hand span. All right. There are different degrees of course. You can have high myopia, you can have moderate, or you can have mild or very low myopia. The opposite end to the spectrum, well, the opposite side of that is what they call farsightedness. Farsightedness is not really as clear-cut as it is because a lot of people who is farsighted, they can't see far and they can also see close. However, the problem with farsighted is that most people, they strain when they have to look close. So with myopia, they're naturally able to see close, they cannot see far. So short-sightedness, you cannot see far. With farsightedness, you can see far. Depending on how it is, you can also see close. It's just that you have a strain. Your muscles is not perfect at looking at things close.
Right.
Yeah. This is short-sightedness and this is farsightedness. Another very common refractive error is called astigmatism. A lot of my patients that I give glasses, they have some degree of astigmatism. What is astigmatism? So we speak about a magnifying glass for myopia, a binoculars maybe for farsightedness. Let us think about a windshield with a dent in it or with a curve. You might be able to see through the parts that's not curved. However, the parts where there is a little dent or the parts where it's a little curved, it's difficult to see. It's almost like looking through a glass that we drink water with. The bottom of it tends to be curved. If you try to look through the bottom of a glass, it's difficult.
Yeah.
A drinking glass. So all of these conditions really have to do with the way the lens in the eyes focus light. All right. So those are the three main conditions that we would observe that really does not lead to any type of blindness.
Okay.
When we talk about, so if that's clear enough, I would like to go on and talk about some further conditions.
Right.
That
So
cannot be corrected.
Right. So before you go, let's just talk about the corrective measures for the conditions that you've spoken of so far. Short-sightedness, farsightedness, and astigmatism. How do we correct that? Or is it something that one we can prevent? Or if not, how do we correct it?
Okay. I'm very glad you used that word correct. Because a lot of my patients, they use that word as well. Correct the eyesight. There is not the purpose of a glasses for a short-sighted person. It's basically your eyes is naturally a magnifier, so we put our binoculars in front of it.
Okay.
The glasses will not change. It will not correct.
Okay.
Or it will not make your myopia shorter or smaller. And if you have to attest to this, once you start to wear glasses, you usually wear glasses all the time. We barely see people wear glasses and stop. So it's not like the glasses fixes a problem or in the body, doesn't change the structure of the lens. The only way to really change the lens is to do surgery. Okay? But the risk of surgery, it's not necessary for someone who has these minor conditions. Okay? So for short-sightedness, all we do, so for example, the lens in your eyes, it's a little, what we would say, a little thin in the sense. It's not focusing light on the retina, it's focusing light behind the retina. We use a, a type of lens that will bend the light where we need it to focus. Okay?
Okay.
So for short-sightedness, how we help the problem is by allowing light. So these people, when light enters their eye, it's not landing where it should. So by the laws of physics, we get the right lens that allows the light to focus where it should focus, so that the brain can pick up the information. Someone who is not myopic, someone who is not short-sighted, their light focuses on an area in the eye called the macula, and the macula is what sends the information to the brain. They do not need anything to change the way light enters to the eyes. So for short-sightedness, astigmatism, or farsightedness, we basically just use a glasses that corresponds to the nature of the problem. Okay?
Yeah. Lovely. Right. So I'm very glad you cleared that up, because as you said, many people use that term corrective to correct, and clearly that is not correct. So yes, it is not correct. Yes,
it might be the correct word, but it's not what we are thinking.
Right. Okay. I understand.
It's not what we are thinking to do. It's not correcting anything.
Yeah. Okay.
Yes, it is exactly what you said.
Right. Okay. Lovely. So we understand that. You just mentioned something, and I think you can take us there. The macula, the area in the eye that sends a signal to the brain. And we're also familiar about a condition called age-related macular degeneration, AMD.
Right.
Yes. Let's talk a little bit about that.
Okay. So how can we explain this in its simplest form? All right. Your eyes, inside this white ball, okay, there is a layer within it. Imagine you have a basketball. You cut it open, you're looking at the inside layer of the basketball right now. Okay?
Yes.
That inside layer, it's filled with cells that detects light. Okay? So let's go beyond we fix your myopia, your short-sightedness, we get the light to hit your macula. All right? But we need that macula. The macula is known as the area in the eye where there is no blood vessels. There is no how to say, there is no area in that eye where you see any blood vessels flow into it. And in that area, called the macula, it has the most concentration of cells that respond to light. This is the very center of your eye. So your retina can detect light from the side. You can put your hands up to the side and you can still detect it. But you cannot focus unless it's directly to the center. Okay? Unless it's directly in front of you, you will not be able to focus on anything. Because the cells at the macula is responsible for center vision. Your direct center. So how you focus, it interprets fine details. These cells, well, also known as rods and cones, in the macula, there are higher concentration of cone cells. Okay? As the condition says, age-related, as we get older, there will be a constant buildup of what we call oxidative stress. So as these cells work, so you have a car, it's working with gas, there is byproduct. Every time your cells interpret information, there is always some sort of byproduct. And any part in your body, your heart, anything that's operating, over time there is byproduct. And what we believe is that these byproducts, these free radicals, causes a stress on the cones, and it's causing them to deteriorate, usually after about 75 years for most people.
Right.
Okay? And this, now, once we look at your macula and we see a decrease in cone function, we see a decrease in cell function as compared to a healthy person, and you are of age, we are considering something called age-related macular degeneration. Because at that macula, we are noticing a reduction, a degeneration of cells. And this is what it is. And so if the area that interprets the light is decreasing, your vision would also decrease with it. There are lots of, we do say that because it has a lot to do with the age, our health, our diet has a lot to do with age-related macular degeneration. There are a lot of studies that show smoking cigarettes is highly related to age-related macular degeneration. Okay?
Right. So we have established that the macular degenerating, of course, is going to affect your sight as well. What are some of the other common ones you come across? So we've looked at the short and farsightedness, astigmatism, and now AMD. What are some of the others that you come across on a daily basis with patients?
Okay. The one thing I should have mentioned with the short-sightedness, and it's one of the main conditions we come across, is something called presbyopia. Presbyopia, pres means with age, like Presbyterian, pres with age. Myopia, the eye. So with age, the eyes lose vision.
Right.
Okay? However, presbyopia is not a condition that sends someone, or it does not make anyone blind. Presbyopia is very common, and it usually starts once a person hits the age of 40. We don't know why the special number is there, but if it's one thing we know as eye doctors, as long as someone reaches very close to 40, they will come into our office and say, Doc, I have to push things further. Yes. I don't know why all of a sudden I pushing things further. All right. This is because the lens, the same lens we're talking about with short-sighted or far-sighted. So you could still have short-sighted, you could have far-sighted, you could born with these things. But regardless, 99.9% of our patients, as long as they reach the age of 40, their muscles, together with the hardening of our lens, makes it difficult to pull things close to focus. Because our lens is not just a piece of glass. It can move like a camera. It can focus at different distance. If you look at a child will hold something very close and read it most of the time, whether or not they have a problem. A lot of times you would see child holding things very close. You would also you would also notice with children, compared to adults, a child will run about and play. You tell a child to sit, they're running and playing, because the muscles in their foot is very active. Just like the muscles in their eyes are also very active. If you tell an adult to sit down, they will be happy to sit down.
Yes,
because
indeed.
the muscles in their foot, it's more in a relaxed state. It's not firing as much energy as it was when it was young. If you could think about that same concept, you would understand that the muscles in our eyes as well, it does get a little more relaxed with age. Coupled with the fact that the lens gets a little stiffer with age as well. It's not as mobile, it's not able to move as much. So because of this, at least 100% of my patients, 40 and over, have some sort of problem pulling things close, because it's the muscle and lens that allows this. and this is presbyopia. This is another very common condition.
Mm-hmm.
Yeah.
Right. Wonderful. And we're moving on.
Yeah.
So we also hear of things like well, color blindness, of course, cataracts, glaucoma. I don't know which one of these three you want to take first.
Okay, so let's start with colorblind because a lot of studies show that colorblind is very prevalent in young males and young African males. So I believe it is very important for Grenadians to know this because Grenada is a population of mostly Afro-Caribbean. Okay, right? When we speak about colorblind, it's a more rare condition. I may have seen in my life about 10,000 patients. I probably only came across colorblindness 3 times. So it's fairly rare. The cones at your macula, the same cones that deteriorate with macular degeneration, they are responsible to seeing light. There are different types of cones. There are red-green cones and there are blue-yellow cones. What these cones does, they interpret wavelength. Wavelength is the characteristic of light. Wavelength is what separates a rainbow into having its different colors: red, orange, yellow, blue, violet. The higher the wavelength would be the red, so it sits on top of the rainbow, and the lower the wavelength would be blue and violet, and they sit to the bottom. Our cones in the eyes are able to detect these different wavelengths. If a person has a deficiency in their red-green cone or their blue-yellow cone, so it's just basically one cone detects certain lights, one cone detects other lights. This will cause the patient to mix up certain colors. Usually, with color blindness, people still see colors unless it's a very rare form of color vision called achromatopsia, where the patient does not see any form of color, they see black and white. This is extremely rare. Something I have never came across, something I don't know any of my colleagues have came across. This is to show how rare it is. But it is there, of course. All right, there are documents of it. This is color blindness. Any questions you have on that before we go on to cataract or glaucoma?
No. We can move on because there are. I want to ask you about, of course, the glaucoma and the cataract. So maybe we can start with the cataracts and then we go to glaucoma.
Okay,
because
great.
there are a couple of things about glaucoma I would like to raise as well.
Yeah, glaucoma is very important. Now, cataract is also very important. A very simple way to define cataract is an opacification or a block, a lack of transmissibility in the lens. So once there is an opacification in your lens, the same lens that we use to focus with myopia, same lens with presbyopia, the cataract now, it's not a matter of the lens having a bad shape. It's not a matter of the lens not focusing. It's a matter of fact that there is an opacification or there is a blockage. So imagine you have your windscreen there and someone takes some paint and splash it on your windscreen.
Right.
That windscreen is your lens, that is a cataract. Okay? Once the opacification is on your lens, as we get older, okay, our lens, the doctors tend to describe it like an onion with different layers. You know, you can unsheet an onion piece by piece. It have different layers in the onion.
Yes.
Okay. As we get older, and the lens itself, it also one wouldn't say deteriorate, but it does what it needs to do with age. Different layers in it changes, and the center or the nucleus of our lens, so the center of it gets dense and it builds up a discoloration. So from birth, when we look at a baby's eyes, we see a very clear lens. We look through that, it's pristine, like looking into the clearest lake you ever looked at. Okay? Cataract is actually comes from a word, I wouldn't know exactly, but cataract comes from a word that means waterfall. All right?
Mm-hmm.
And waterfall is a good way to explain a cataract. Because if there is a waterfall and there is a cave behind it, you wouldn't see what's in the cave.
That's right.
The waterfall is blocking the view to the cave itself. Okay? And let's say your macula is the cave. So light needs to reach your macula to reach your brain. Once there is a discoloration, once there is something stopping light from going through, we will consider this a cataract. Okay? And we consider a cataract significant. So you could plainly describe any sort of opacification in the lens as a cataract. But when it becomes significant is when it inhibits the patient from seeing at least 20/30. 20/30 is a line. If you ever go to the optometrist office and they give you the chart, 20/20 is what everybody know about ideal. If we correct you with glasses and you are not reaching to 20/20 and there is an opacification in your lens, there is no other reason for your vision to be weak, we know that this cataract is significant because it is affecting your vision in a way that glasses itself cannot help.
Right.
This is when it becomes significant. This is when it's very mild as well. As we get older, sometimes as well, if we have certain condition like diabetes, we develop a plaque or an opacification on the lens. So it does not just need to be with age. And as long as there is this blockage on that lens, we will not see. Cataract is the leading cause of blindness, the leading cause of preventable blindness worldwide. Okay? In Grenada, we see a lot of what we call dense cataract. Cataract that should have been removed long time ago.
Right.
A main reason for this is because what I experienced, a lot of individuals, surgery is something that could be a little scary. And a lot of individuals, they always go with the idea that the glasses is what they would need to fix the problem.
Okay.
So they end up by the doctor and say, look, you have a little cataract. We think we should monitor it. Well, doc, when you give me the glasses, I'll be good to go, Get the glasses, they see brighter. Some years pass, 2 years, they come back, check their eyes. The cataract is getting bigger. We should consider doing a removal and assessment. You should consider going to what they call an ophthalmologist. An ophthalmologist is the person that removes a cataract. An ophthalmologist is the person that we will have to send any extreme cases to.
Right.
So, yeah, if we are your primary eye care provider, your ophthalmologist is your final stop. You understand what I'm saying? If there needs to be surgery, you need to see an ophthalmologist. Once cataract needs to be removed, you need to see a surgeon of the eyes. An ophthalmologist will go into your eyes, they will remove the lens and replace it with a new lens so that there is no opacification no more. This is why it's preventable. However, because a lot of people, I don't think they're scared, but it's what I realized with a lot of my patients, they would quicker put off a cataract surgery. It would be very easy for them to put it off. But when you constantly put off cataract surgery and you're 70 going on to 75, then you're going on to 80, there will be a point when the surgeons will say, look, you're at an age now, I think it's a little too risky. So we miss our sweet spot. We miss the time that it should be removed properly. And most people, what I realize, they wait until the eyes go completely blind before even considering to remove a cataract. The problem with this is you are trying to remove a big stone from a wet piece of paper. There will be damages.
Okay.
You understand? And this is why it's very important that the people of Grenada, the people of the world know that it's good to do, especially after 40, annual eye exam. Always ask, Doc, have any cataract? Have any glaucoma? Have anything to worry about with my eyes? Ask questions when you go by doctor. What's going on with my eyes? What should I do to keep or maintain the health of my eyes for a long period of time? This is cataract. You understand that cataract is just basically the lens has a blockage. The only way we know to get rid of it is by surgery, because where the cataract is located, it's, sometimes I hear talk, put some castor oil things, cataract. I hear these talk, which it's not, everything doesn't come from nonsense.
Right.
There is a reason why people say it. It's just that at least 50, 60 patients of mine use castor oil on the eyes and they have a cataract. So it's not that we are trying to fight against natural remedies. It's always to know what it's actually doing. You cannot see a cataract in my eye. I cannot see a cataract in your eye unless I have an equipment.
Right.
A lot of people in Grenada, they mix up a cataract for a condition we call pterygium. Pterygium is where you see a white flesh growing over the eye, which is what's very common in Grenada. It's usually caused when UV rays hits and bounces off the bridge of the nose and strikes the eye, causing a constant irritation and causing a growth on the white of the eye. If the irritation continues, it could be from UV rays, it could be from dust as well. If it continues, it grows until it covers the baby of the eye. And that is a pterygium. So a lot of individuals, they mix up cataract with pterygium,
Indeed. In fact, well, you preempted me there because I was about to ask you about that. So it's good that you've cleared that up. Right. So what you mentioned a little bit of the cataract. You mentioned that the patient should question the doc and things like that regarding cataracts and other little things. But shouldn't the doctor also make necessary recommendations to the patient? I mean, because the doc is the one that understands better what the outcomes can be if these things continue. So I'm asking, shouldn't you make the recommendations and say to the patient, look, there is a cataract. It is better if you removed it now than if you waited a couple of years down the road, because if you do, removing then can result in little damages. So, let's get it done now and explain to them, what is involved and all of that.
Definitely, it is expected. It is expected that the doctor should have the best interest for the patient. However, it is up to the patient to have the best interest for themselves.
Agreed.
If you see, I can speak for myself. You don't have to ask me. I'll tell you everything that's going on with your eyes. However, just imagine you check in the hospital where the place is busy. Doctors, they're dealing with problems. They're not dealing with education. They're dealing with problems.
Right.
So they're seeing a problem, they're fixing the problem. They're not there to really educate, they're dealing with the problem at the moment. So I'm not saying that doctors will leave you there without any recommendation. I am saying for you, the person who has the problem, the person who has the eyes, they should ensure. So that would only go unless your doctor does not give you any information. If your doctors don't give you any information, you take it upon yourself to ask the questions that's necessary. But I believe firmly, a great part of medicine is in advice.
Right.
It's in the way you talk, the way you speak to your patient. Education is like the most powerful tool. Once you are educated, you know how to go about your business. So definitely, I back you 100% on that. It should be that way. It's not always that way, but it should be.
Right. I just want you to, because I think that is very important. And I have to confess that the pterygium that you mentioned, I think I also thought this is what a cataract was.
Yes, definitely. I mean, this is very
I think it's important that you sort of maybe just go over that quickly so that our listeners understand the difference between a cataract and the pterygium.
Okay. Pterygium is something that anybody can see with their naked eye.
Right. So you can see that.
That's right. You can have a very big cataract, and I could still miss it with my naked eye. As the eye doctor, as the specialist. Because what would happen? A cataract is located, you see this iris, the colored part of the eye? Okay? It's like a little dot, a white dot inside of that. That's the only way to see a big cataract. And once the cataract is not big, it's impossible to see with the naked eye. Impossible. And most people, cataract is not big, because once it's big, it means they're blind. All right? And we use a machine called a slit lamp biomicroscopy. This is like a magnifier. You see those magnifying, you magnify cells, you see nice and big?
Yes.
We use a machine like that for the eye. So we take this little eye, and it expands big like the room for us. So we see every single, and this is the only way we are able to see this cataract. Huh? So it's very easy to distinguish, because you will not see a cataract so easily. You see something big and fleshy on the eye, it's a pterygium.
And that could be removed. You can go to the ophthalmologist and...
Yes, definitely. Pterygium is something that is very common in Grenada because of the coastal line. Okay, there's a lot of sun, and then we don't use shades. If just today I was talking to some fishermen in Soubise or Marquis, and at least 7 of them, we're there and they're talking about, we are buying some kingfish, and they're saying, boy, all you gotta give you some shades. And I say, but at least get something and put it on your eyes, protect your eyes. I say, look, every fisherman here, they have this little red thing on their eyes. I say, and everybody could see that fisherman have these things. So they know,
Right.
People are around the sunlight, they know what's going on as well. They just might know exactly, what's causing it. They might just know, hey, we have this, but they might think it's a cataract, unless they're educated, unless they go and they find out for themselves.
Right.
Huh?
Excellent. Great. Glaucoma.
Right.
We hear about this one almost every time you mention the eye and an eye condition. Glaucoma definitely comes up.
Okay. To understand glaucoma, we need to understand how the macula sends the information to the brain. So the macula gets light, takes the light, it literally harnesses the light, and sends the light information to what we call our optic nerve. And our optic nerve is an extension of our brain. It connects to what you call an optic tract in our brain. Our eyes is within our brain. Our eyes is an extension of our brain. Okay? The optic nerve is what really relays the information. Your optic nerve is like the cord between the switch and the light bulb. If you understand what I'm saying. It is connection that sends the information to the light bulb to spark.
Right.
The optic nerve, it's a nerve, as you can know. But it does not detect pain. It detects light. And not detects, it transmits
light
information. Okay? Just like how, I don't know if people are aware of this, but you cut your nerve in your hand, it gets numb. you wouldn't have no feeling there again. You cut the nerve in your back, you cannot walk no more. The nerve is unable to operate, you get paralyzed. The optic nerve in the eyes, it's very delicate. So once this optic nerve experiences any sort of pressure, it tends to get damaged. So what we could understand is glaucoma is a progressive damage to the optic nerve, usually caused by high eye pressure or high intraocular pressure. And this is simply, on its simplest form, what glaucoma is. It's a progressive damage to the eye nerve that sends the information to the brain. Glaucoma is the leading cause of irreversible blindness. So cataract is the leading cause of preventable blindness and reversible, so you can fix a cataract. Glaucoma, just like how you cannot fix someone who is paralyzed, you cannot fix the nerve in the eyes once it's damaged. So I believe glaucoma is the most serious condition that we have to deal with, because glaucoma does not give you any sign. It does not give you any idea that your nerve is being affected, because it happens so slowly, so subtle over time. Usually, sometimes it takes 30 years for glaucoma to really do its damage, but it's doing it slowly. The problem with glaucoma, a cataract would affect your center vision first. So you pick it up, you tend to pick it up early. People tend to go out in the sun and say, look, I'm getting this smoky, this hazy vision anytime I'm going out in the sun. We tend to know that's a cataract. With glaucoma, it affects your peripheral vision first. And no one is really conscious of their peripheral vision. When we get up in the morning, we don't get up and say, hey, I could see all the way to my sides. We only focus on what we see close. So you can have glaucoma, you can have high pressure. We have a lot of people with high pressure in the eyes, and they don't feel anything at all. So they don't feel the pressure, they don't feel nothing like that. And so you don't have no symptom. You're seeing nice and clear straight ahead, but slowly your vision could be decreasing until you tend to get a tunnel vision, where you only see through a very small area. After that tunnel vision, there is complete blindness. Glaucoma, we believe, is very prevalent in Grenada. A study in Barbados showed that glaucoma is higher in Afro-Caribbean population. A study in Africa shows that glaucoma is higher in Africans. A study in America, in the United States, shows that glaucoma is a higher prevalence in African Americans. If we do the maths, if we look at Grenada's population, it is very important that everybody is screened for glaucoma.
So ethnicity does influence glaucoma in a large way.
What's that? Sorry?
No, I was saying ethnicity. It does impact, yes, glaucoma.
Yes.
Right.
And then as we go further, we recently begin to discover it's certain genes, like the GAPAC1 gene, that is prevalent in certain Africans that have the glaucoma. So if we were ready to go in depth and really study this, if we were to spend time and money, not us, me, the eye doctor, but generally the scientific community, if we were to spend time and study this, we would gain answers. We would understand deeper and deeper, and we will gain knowledge to pass on to the next generation, so that maybe somebody at one point would be able to cure glaucoma. Glaucoma is not curable.
Okay.
Glaucoma is treatable. And once glaucoma is picked up early and we treat your high pressure, it can be avoided or it can be slowed down the damages that it causes. Okay?
Okay. 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 There is also something referred to as juvenile glaucoma.
Yes, so juvenile glaucoma is very, very same. Okay, so what's causing this damage in the nerve is usually high pressure.
Mm-hmm.
Okay? And high juvenile glaucoma is just basically glaucoma in children.
Okay.
All right? High pressure in a child's eye will damage the nerve from early. Even with children, it's very important to pick it up early. That's why no matter where you go in Grenada, no matter how or who you go by, they will check your eye pressure. Most important. Okay?
Right.
And juvenile glaucoma and there's also congenital glaucoma where the baby is born. And recently I just made my well, not me, my wife did all the making. She recently made the child.
All right.
And the first thing they did was placing an IOP lowering drop, which I thought, well, all you're real proactive because all you know thing, man, you know?
All right. Yes.
The first thing they do, they say, put that Timolol in them child eye because it's still lower the pressure. I don't question, I don't think anything, but I looked at it and I say, and that's kind of good.
Yeah.
You know?
Yes.
Yeah, because it's better to be safe than sorry sometimes.
Yes. You take in front. Oh, definitely. Right? Most definitely. Definitely. Yeah. Quickly, before we get to I think what might be the most important part of the discussion, quickly, pink eye. We have pink eye.
Okay.
Yeah.
All right. So now, this is another thing I really like to talk about as well. Mm-hmm. Pink eye or red eyes or epidemic keratoconjunctivitis. And it's usually epidemic viral keratoconjunctivitis.
Okay.
You should think about pink eye in the same way you think about COVID.
Okay.
And when I think about pink eye, it might be the same thing, same term Trinidadians use as Grenada, so let's clear it up. Pink eye or red eyes is the term we use for this condition where the eye, you have red eye and then everybody gets it.
Yes. Mm-hmm.
Right?
Yeah.
So this is the term. It's not pink eye or red eye if it doesn't spread. It's not. It's not because if it's not spreading, it's not red eye. It's not the condition. It's not the term that we use. You know, we use red eye when a child gets it, another child gets, hey, red eye is
yes, yeah, red eye going wrong. Yeah. Mm-hmm.
You could also have a pink eye, one single eye that's red due to a bacteria. It does not necessarily mean it's what we call a red eye. But what we call red eye is usually a viral epidemic keratoconjunctivitis because epidemic just means that it's spreading, you know? And it's usually a viral because a virus is easier to spread than a bacteria.
That's right.
Usually a bacteria needs contact to spread. A virus, and what they know, there are many viruses that can cause red eyes. One of it is adenovirus. You tend to get a little fever with it, but you have the virus, you sneeze, goes to someone else, it affects the eye.
They get it, yes.
Someone else. Sometimes they breathe, and that's how it spreads. So, and a virus, it can be in the air, it can multiply all over. So it's much easier to spread. So it's just basically a viral infection in the eyes or the upper respiratory tract or your sinus that leads to, that spreads amongst individuals. So this is what red eye really is.
Okay, wonderful. So last but not least, very important, diabetic retinopathy.
Wonderful. You have the best person. You is one of the best persons I ever spoke to, my brother. Right? Diabetic retinopathy. I don't know how much more I could stress on this thing. Mm-hmm. It is the last thing I want to see in my patient in Grenada.
Right.
Because there is no vitreoretinal specialist in Grenada. We do have a lot of excellent ophthalmologists in the hospital, excellent eye doctors. However, when it comes to diabetic retinopathy, your condition is located in a layer in the eye that's almost as thin as a strand of your hair.
Ooh.
To fix this problem, you need to be an eye surgeon that specializes further. It is something that I believe in Trinidad, we may have only about 3 or 4 retinal specialists for the most. Okay? And the retinal specialist for Grenada usually comes down twice a year via SGU.
Right.
Recently, they did some training with the doctors in the hospital. So there is a doctor there that is able to perform anti-veg therapy. So with diabetic retinopathy, you develop bleeding in the eyes. So the capillaries in the eyes, they get weak, they burst, they start to bleed. The capillaries that's on the retina.
Mm-hmm.
Once there is bleeding in the eye, you know, you could hear that and you know that's a problem.
Yes, indeed.
Okay? This is not on the outside, this is on the inside.
Mm-hmm.
This is same situation that goes on with your foot with diabetes.
Mm-hmm.
Okay? All the little vessels, they tend to rupture. You see the swelling, you see what goes on with the foot. Similar situation goes on with the eyes. There is early bleeding, and it's highly related to your sugar level.
Right.
As long as your sugar goes over 200 for a prolonged period of time. So when it comes to the eyes, we don't care about your sugar when you don't eat. We care about your sugar at the highest it is.
Mm-hmm.
So we don't care about checking your sugar when you're fasting. We want to know what your sugar is. You
Right.
eat some ice cream, you eat some provision, you eat this. How high does your sugar get? That's the problem.
Right.
Okay? Because the higher sugar level for a prolonged period of time will cause bleeding. Ideally, once it's picked up early and it's just bleeding on the retina, it's not in the deeper layers of the retina, an injection, also known as an anti-VEGF, something that stops bleeding and it stops new vessel growth, will inhibit or it will stop further damage at the moment. However, because the problem is from high sugar level, once your sugar goes back up,
the problem returns.
The problem will continue. All of this can be avoided once we get the patient to sit down with a general practitioner, do a full detailed check from early. This is before we pick up anything.
Mm-hmm.
You have diabetes, you do annual diabetic check of the eye.
Mm-hmm.
You ensure there is no the first signs we tend to see is dot hemorrhage. So tiny little dots of bleeding. Tend to see it from very early. And once we pick it up at this stage, the patient is very compliant. It's very easy, let's not say it's very easy. Unless you in the patient's booth, you would not know how hard it is sometimes to control your blood sugar level. So we cannot say it's easy at all. Because if it was easy and they know the eyes will give them problems, it would have been done easily, right? So we know there is some misconception and there is an inability of patients to really bring their sugar down with the medication they're taking. There are individuals who are able to do it, but there are some individuals, sometimes they don't react to the medication properly. Sometimes they eat food that they believe is good, but it does have a lot of starch, and starch converts to a lot of sugar.
That's right.
A lot of sugar in the body is difficult to be removed. It stays in the blood. It can form toxicity. It can damage the vessels in the eye. Diabetic retinopathy on its simplest form can deal with an injection. However, once it goes deep within the layers and it separates the layers, you ideally need to see a vitreomacular specialist, okay, a vitreoretinal specialist, which only comes down about twice a year in Grenada. So my best advice, as soon as I see any sort of bleeding, any of my patients, I sit them down and I say, look, listen to me. Sorry to say this, but you need very, very, very important that you bring this down. We check you back every month. We referring you to the ophthalmologist. Still, regardless, we still refer you to them. You understand? But we're checking you back every month. We're making sure there is no progress. Check your sugar. You can come in the office, check your sugar if you have to. Because if you care for people and you know what's going to happen to them, you would really want them to know, look, this could be avoided. It could be, you know?
Right, wonderful. So I'll tell you what, let's take a short break. When we come back, we're going to open the telephone lines and give our listeners and viewers the opportunity to ask any questions that they may have, and so we can assist in whatever way we can. So stay with us, folks. We'll be back with you in just a moment.
Diabetes, AIDS, cancer.
The Planning and Development Authority of Grenada, PDA, is enforcing regulations to curb illegal, disorderly, and unauthorized development in several locations throughout the state of Grenada. The authority is concerned that structures mainly associated with vending are negatively impacting the environment, has undesirable public health and sanitation consequences, present obstructions to vehicle and pedestrian traffic, can become projectiles during adverse weather conditions, and generally affect the aesthetics of the nation. The PDA will work along with stakeholder ministries and institutions to effect the demolition, removal, and disposal of structures which fall in the category of illegal and disorderly development, commencing January 2024. In this regard, persons who vend in or occupy such illegal structures are advised to secure their personal belongings and have the structures removed ahead of the planned PDA demolition operations. These actions of the PDA have become necessary to safeguard and protect public health and the environment, ensure the safety and well-being of all citizens and visitors, discourage any future disorderly construction, and encourage compliance to regulations pertaining to physical development in the state of Grenada. This is a message from the Planning and Development Authority of Grenada.
I'm a VIP. I'm a VIP.
I am a VIP. I am vaccinated. I am immunized. I am protected. Our children and nation depend on vaccination for immunization. Childhood vaccination is national priority. It is their protection from disease and sicknesses. Let's all be VIPs and safeguard our beautiful Grenada. I am DJ Blackstorm and I am a VIP health champion. Be a VIP like me.
Let's all be VIP champions.
A message from the Ministry of Health, Wellness and Religious Affairs, Be a VIP Childhood Vaccination and Immunization Campaign in collaboration with UNICEF and the Pan American Health Organization.
Have you heard about the new Softweave bathroom tissue with total hygiene? As hygiene and safety have taken center stage, our bathroom tissue is now manufactured with 3 different technologies to offer the best protection for you and your family. UVC light technology for a safe and effective disinfection process, eliminating 99.9% of microorganisms. Also, production at high temperatures, killing all types of germs and bacteria. And it's pH controlled with delicate fibers to prevent irritation for even sensitive skin. Softweave Total Hygiene Bathroom Tissue, available in supermarkets and shops island-wide. Visit Softweave Caribbean Facebook or Instagram pages for more information.
Abuse, cancer.
Well, Welcome back, everyone. It's Doctor and Call, and with us this evening we have Mr. Ryan Singh. He's the optometrist, and he's been sharing a lot of wonderful information with us. And I hope you've been paying very close attention. Our telephone line is open, and so we're going straight to the telephone this time. Doctor and Call, good evening. Hello. Yes, good evening, caller.
Yeah. Apparently, I was arrested and charged in St. Vincent for being in possession of marijuana, and the police continue hitting me in my eye with a finger, in the both eyes. After that, I developed glaucoma. I wonder if that could really cause eye to glaucoma.
You said that you were constantly being hit in the eye?
Yeah, with the finger. You ever when they do the finger and hitting me both eyes. Boy. And after that, now I just developed glaucoma.
Okay. But let me just ask, have you been having problems? I mean, what does your eye hurt? Does it what happens?
No, I using optimal and Litinox. You understand, for the pressure of the eye.
Oh, okay.
Can't see too well.
So you want to know if that could have caused your condition?
Yeah.
Okay, Doc. You heard him? Yes. Okay, caller. Thank you. Mm-hmm.
Okay. What I gathered is he got a lot of injuries to the eye.
Yes. Yeah. He's been hit in the eye. And apparently he's talking about the pressure in the eye. So he wants to know if that may have resulted in the glaucoma.
So yes, it's very interesting that he was stated in such a clinical textbook way. There's a condition with boxers. You know, boxers, people that box.
Mm-hmm.
What happens is, from the constant trauma, from constantly getting lashed to the eyes, there is a part in the eyes called a trabecular meshes. This allows for fluid to filter out. If constant trauma damages this trabecular meshes, it disrupts the way fluid is released, and it can build up the eye pressure. And we tend to see with these boxers, they develop glaucoma later on in life.
Okay.
So it is very possible that a prolonged period of trauma to the eyes, especially knocks and cups and points, whatever you want to call it, can damage the trabecular meshes and lead to glaucoma in its most textbook form. So you wouldn't see it like a damage. It's just these people just developing glaucoma after a time.
Mm-hmm.
You could also get a severe punch to the eye, and that pressure, that force, can also damage your nerve, very similar to the way glaucoma will damage your nerve.
Okay.
So it can definitely cause glaucoma textbook, and it can definitely damage your nerve and make it look very similar to glaucoma. So it is very possible.
All right. Okay. So, caller, we hope that that information has helped. And of course, we want to encourage you to continue to take good care of your eye. Whatever instructions that you've got from your doctor, you should follow and do necessary to ensure that you, minimize the problem as much as possible. Right. The number is 435-2041. So those of you who have any questions that you would like to ask, you can give us a call now. The number again, 435-2041. Or those of you on our Facebook page, you can post your question there. We will get them. And of course, those of you on the WhatsApp platform, you can also post your questions there. It's the same 435-2041. And we'll be more than happy to provide you with information. Let's go back to our telephone. We have another caller online. Doctor and caller, good evening. Yes, good evening, caller.
Yes, Godfrey, I'd like to ask the doctor to explain what is a narrow angle. I listen on the radio. What is a narrow angle? I've been to the doctor once and he told me I had a narrow angle. I'd blind to do. But at a narrow angle. I want an explanation for that.
Okay, thank you very much, yes.
All right.
A narrow angle, doc, yeah. He wants some explanation.
Okay. Okay, so he may have something called narrow angle glaucoma.
Narrow angle glaucoma, okay.
Okay? Now, when you speak about the angle and narrow angle, let's try to clear it up for the audience as well. Okay? There is a position, there is a structure in the eyes, the same structure that we mentioned that can get damaged, called the trabecular meshwork. All right? If this is your eye right here, your eye has a curve, there is a little corner, a little angle within the eye. And right at that angle is where the drainage is. Okay? So let's say this is the channel, okay? Where where aqueous humor needs to exit so that your pressure remains balanced. So it's nice and open now. But if this angle was closed, less fluid will be able to exit through that angle.
Right.
When we say narrow angle, we look at a person's angle or the Van Herrick angle, and we grade it between 1, 2, 3, and 4. Once this angle is narrow and your pressure is high, we call it narrow angle glaucoma. If the angle is narrow and your pressure is okay and your nerve is okay, you just have a narrow angle. And with people with a narrow angle should be monitored closely because they are more susceptible to develop angle closure glaucoma. Angle closure glaucoma is an emergency. It has been shut. This is not the normal tension glaucoma. This is a glaucoma where the eyes is in an emergency. It needs to be open. You need to go to an ophthalmologist to get a laser or some form of measure to open back that angle.
Okay, lovely, lovely indeed. 435-2041, that's the number you can call, and you can ask your questions. Let's go back to the telephone. Doctor and call, good evening.
Hello.
Yes, good evening, caller.
Yeah, I come back again. What has happened? I get some medication from the United States, right? Called artificial tears. And I was listening to the BBC News every night. But what they was announcing that once you have the combining compound CVS, you should not use it because it cause blindness. One time I look at it and I see CVS and it, I feel, let me put it in a corner. And from that I never use it.
Okay. Caller, can you just, the doctor didn't hear you too clear. Can you just repeat that?
No, they said that once you're using any compound with CVS in it, that has CVS in it, you should try to prevent yourself from using it.
That has what in it?
CVS.
CVS. I'm not sure what.
It's a compound within it.
Okay.
What CVS, what compound is it specifically? I wouldn't be too sure about it.
Okay. Well, he's just saying that he was given apparently this medication that contained what is supposed to be CVS. I'm not sure what it means. I don't know if it's a brand. I don't know if it's a compound. I am not sure. I'm not sure what it is.
Let me just look it up on my phone.
Right. Okay. Yes.
So we can probably get a better idea of what.
Yeah. All right.
It's in a medication use.
Apparently, yes. Yeah. That's what he said. In the meantime, though, let's go back to the telephone. We have a caller on the line. The doctor called. We lost that caller. So I know of a brand called CVS, but I'm not sure.
I do see that CVS is a brand of eye drops. Okay. And he may know what he's talking about because it's a brand of eye drops that was recalled in the US for carrying a possible infection. So maybe he looked up that.
Okay. Well, he actually said he heard it on the BBC.
In the?
He heard that, he got that information from the BBC. The BBC News.
Okay, lovely.
So
lovely.
he's yeah, okay, lovely.
Yeah, so it's a recall drop in America. We don't really have that ingredient.
Okay, great. Let's go back to the telephone. Doctor on call, good evening. Caller, can you turn the volume of your radio TV down, please? Hello? Hello? Okay, the number is 435-2041, and call us, please. When you call, please turn the volume of your radio or your TV down and listen to us on your telephone. All right? If you don't do that, we won't be able to hear you clearly, and it could create a problem. So the number again, 435-2041. You can give us a call and share your comments or questions. Let's go back to the telephone. Doctor on call, good evening.
Good afternoon, Mr. Godfrey. How are you doing, man? Why are you hearing my voice?
Can you turn the volume of your radio TV down?
Turn it on here. Yeah, I'll do that stuff. Turn the volume. Yeah. Doctor on call, boss.
Boss.
Yes, go ahead. Mm-hmm.
Yeah. Doctor, I want to ask you a question. Does masturbation cause anything to your eyesight in terms of,
Okay, caller, we got it. All right, thank you. Mm-hmm. So he's asking, Doc, if masturbation can affect your eyesight.
Okay, well, let's say that there is no clinical studies that have ever been done at this moment that can show any relationship to masturbation and decrease of eyesight. So I know they talk very well.
Well, I was about to say that
you have nothing to worry about.
Right. Yes. Okay. So yeah. So guys, no harm with masturbation and blindness. So, all right. 435-2041. That's the number you can call, and we'll be happy to take your call. In fact, we have time for maybe 2 quick calls before we wrap for tonight. Time goes by really quickly, and I'm sure Doc will not object to coming back to the program another time, to do some more educating. Let's go back to the telephone. Doctor on call, good evening.
Good evening, Godfrey.
Yes, good evening.
One question. This doctor attend in Grenada, the doctor that they know?
Yes, he does. He's at Clear Vision Eye Center on Sittenbrong Street in Grenville.
In Grenville? Oh, yes. Not in St. George. How you could get him down to St. George?
No, he's in Grenville. But you can go to St. George's too. There, Clear Vision does have an outlet on the Carnage in St. George's, so you can also visit there if you need to do eye examination and so.
Yeah, but what I really have cataract. I do surgery on it already. Then when it's little, and do surgery on it, and I find on the right side getting kind of darker, seeing darker.
Okay. Well, I would suggest you visit them and let the optometrist have a look into it and see what is happening, and of course you will be advised accordingly.
And the Carnage?
Yes, you can go to the Carnage. Yeah, that's close to the food fair there. Yeah.
Oh, okay.
All right. Thank you. No problem. Yeah. Yeah, he says he had cataract surgery before, but he thinks that maybe there could be a little resurgence, so he wants to have it checked again. Yeah.
Okay, that makes sense.
Yeah.
You could definitely check, especially if your cataract has been over 10 years, it's good to be checked.
Right. So we have time for one.
Still check it every year.
Yeah. Let's take our final call for this evening, and then Doctor in call. Good evening.
Yeah, good evening, Doc.
Yes.
I would like to find out. Hello.
Yes. Yes.
Yeah, I would like to find out what causes your eyes to be making the yampy as often as possible.
To make what?
The yampy, the kakaji then.
Oh, okay. All right. Yeah, no problem.
Good.
All right, thanks. Yeah. So he's asking Doc about the build-up in the eye. So, for example, when you wake in the morning, there is a build-up in the corners of the eye. He's asking what causes that.
Okay. So, my brother, within your eyelids, there are glands called your meibomian glands. And those glands, they produce meibomian oil. The yampy, the kakaje, the mucus, as we tend to call it, is a buildup of these oils. The eye constantly produces these oils, and it mixes with a gland that produces water. So the white part of your eyes, it creates something called mucin. That's more what the mucus is, all right? And that mucus is on your bottom layer, on the white part of the eye. Then the eyelid, the eyes is so beautiful, the eyelid produces an oil called the meibomian oil. And then there is another gland that produces more aqueous, a more kind of watery substance. And the oils and the mucin, they keep the water inside there. So your tears is really 3 layers. And it needs to have a perfect combination in order to be tears. And what you're noticing in the morning is that, well, basically there is nowhere for it to go. You're not blinking, you're not doing anything. So any little extra oils or mucin that develops overnight, because of the shape of your eyes, because the way God created the channel of your eyes, it always channels down towards the nose,
right,
where there is a drainage. When your eyes is closed, that drainage is locked. So it has nowhere to go. So you usually tend to see it build up on the outside. If you are waking and you have an overproduction of mucus, it can also be a sign that you have an infection. Whenever there is an infection, your body creates the mucus to kind of get rid of the bacteria itself.
Okay, wonderful. So, caller, we hope that that was helpful. Doc, we're basically out of time. So what I would ask, maybe briefly, just to kind of summarize the discussion, and then we'll wrap for this evening.
Okay, well, I might be able to summarize. Well, say some important points. The health of the body determines the health of the eyes. Your eyes is part of your body. Drink a lot of water, eat a lot of vegetables, protect your eyes from the sunlight, protect your eyes from the computer lights. Don't stress, be happy. Stress affects your eyes. There is a condition where stress could not send you blind, but it could affect your eyes, could cause a lot of blurry vision. Healthy living. Main thing, constant checks on the eyes, constant checks on your body. Ensure you're eating healthy. Healthy means any food you find in the market in Grenada.
Right.
Healthy.
Right. And of course, you mentioned earlier, it's always good to have your eyes examined annually or every 6 months or when?
Usually between the ages of 0 to, well, not 0, about 1 to 15, 17, sometimes require once every year. Then from like 17 to 40, you could check every 2 years. But for sure, once you cross 40, check your eyes every single year. Because glaucoma is higher over
40. Okay.
You want to pick up glaucoma as early as you can.
Okay.
Diabetic retinopathy, hypertensive retinopathy, there is cholesterol that could affect the eyes. You want to pick up anything early.
Wonderful. So, Doc, I thank you very much for accepting the invitation to be on the program with us this evening. I have learned some things I did not know, and I'm very grateful for that. And I really do hope our listeners and our viewers, they did learn as well. And of course, information like that only helps us to, it puts us in a position to take better care of ourselves. And in the case of our eyes, it is so very, very important. So thank you very much. And of course, by extension, the staff at Clear Vision, we thank you all. And we're looking forward to having you back sometime soon.
By the grace of God, God willing.
Thank you very much, Doc. All the best. Thank you, viewers, for staying with us. It was indeed a pleasure. Until next Tuesday, do enjoy the rest of the week. Have a good night. All the best.
AIDS. Cancer.
Drug abuse, cancer,
Measles, diabetes, AIDS, cancer,
drug abuse, cancer,
measles,